Welcome to the Franziska Show podcast on JewishCoffeehouse.com, a show on where I give a voice to Jewish issues, topics, and people. I'm Franziska Faigie, your host. Make sure to hit that like and subscribe button, leave me a comment. You can join our WhatsApp discussion group, and I hope you enjoy this episode. Let's get into it. Today we are speaking with Faige Itzkowitz, a proud listener of the Franziska Show and active participant in the WhatsApp group. Welcome to the show. It's so great to have you.
Yeah, so nice to finally meet face to face.
I know, it's great to put a face to a name. So the reason we're having you on today is to talk on women's health. Last week's episode did very well, but that isn't enough, and we need to go into this topic a little bit more, and I'm happy to be the platform for these conversations to happen. So we'll cover the topics of pelvic floor, women's health, and maybe more. And let's just dive in. Tell us about yourself, professionally, religiously. Feel free to add in any comical stories about the Franziska Show.
Sure. I mean, I feel like sometimes the entire chat is just a comical story. Hi, I'm Faige Itzkowitz. I'm a pelvic floor therapist based in Brooklyn, New York. I'm an Orthodox Jew, born and raised. And I don't even remember when I first heard about this field, but like just something about me just like spoke to my neshama, helping Jewish women, and especially in an area where like it's still developing. People are still not aware of like all the different things that they're suffering with that, you don't have to live like this. My husband's a rabbi, a chassan rabbi. I hope to start teaching Kala soon. And, it just, not sure where I'm going with this help.
Okay, so tell me, how did you get into this field before you were married, after you were married?
I got into this field actually, like I really got into it after I was married, but I'd heard of it beforehand, and I thought it was interesting. But then I got married in my second year of OT school, and that's when I really just started to realize how much of a world there is in terms of Jewish women's pelvic health. I started to learn more because, once you're married, you're all of a sudden in this world of taras mishpacha, of women's health, of pregnancy, of giving birth. And I learned all these things that people don't talk about. All of a sudden I was finding out about. And I was also finding out about all the things that can go wrong along the way. So there's just so many things that go right, like you were talking to Dr. Hellman about last week. But there's so many things that sometimes need a little bit of troubleshooting, need a little bit of help along the way. So let's start with your Kala. And you have to do bedikas. Can you actually physically perform the bedika? If you can't do that, then you have a problem right there. That's going to lead into an issue after you get married. Understandably, you're going to have trouble with intercourse. You're going to have trouble with gynecologic exams. But let's say everything with that goes smoothly. Now you're pregnant. All your ligaments are loose. You might be having pain in various different areas. There's so many different ways that can show up while you're pregnant. And, everyone tells you, oh, wait it out. It's fine. Wait it out. Eventually you'll give birth. You'll be fine. Birth causes so many new issues. So now you can stack that on top. And these are things that don't happen to everybody, but they're so common. Actually, I have some statistics about pain I'll talk about later, but it's extremely, extremely common after birth to experience incontinence. It's like staggering the amount of women who experience incontinence at some point in their life.
What's incontinence?
People hear incontinence, they're like, I don't have incontinence. It's when you can't hold in your urine. So even if you're just leaking, like when you sneeze or when you cough, that counts as incontinence. And there are so many women out there who are like, oh, I guess I have incontinence. I pee when I cough. Now, listen, if you're living your life and you're fine, you can go on living your life. But for a lot of people, it bothers them. And some people experience it to a much more severe degree. I would put that as like the top number one problem. As soon as I tell people I'm a pelvic floor therapist, I could be like talking to like, I don't know, my mother's friend, random people who I meet. And they're like, all of a sudden, everything spills out. Like you would think, what I'm saying? Like when I first learned about the statistics, when I first learned about how prevalent it is to experience incontinence among women.
So tell us the statistics since we're talking about it.
Give me a second while I look it up.
Our WhatsApp group loves statistics.
Oh, yes, they do. Hold on. All right. So according to a 2010 systematic review, 33% of women experience any type of postpartum incontinence in the first 3 months after giving birth. But the rate of incontinence in general is going to be a lot higher because you have up to 84% of women experience genitourinary syndrome of menopause. And it doesn't only happen in menopause. It can happen while you're breastfeeding. It can happen for other reasons. That's why I've heard talk of renaming it genitourinary syndrome of hormone deficiency. But part of GSM or GSHD, whatever you'd like to call it, part of that is incontinence. And that can affect up to 84% of women. People know it as vaginal atrophy, but it doesn't only affect the vagina. It also affects urinary symptoms. And that's why the term is GSM, genitourinary, the urinary part. Incontinence, super, super prevalent. 33%, that's a huge number. And that's just for postpartum. Across the lifespan, most women are going to experience incontinence. Hold on, actually, let me look up the stat on that. I found the stat. Up to 50% of women are going to experience incontinence. Okay. It affects 50% of women. So there you have it. That is a lot. That is 1 in 2.
You went from 80 to 30 to 50.
84% are experiencing genitourinary syndrome of menopause that may or may not come with urinary symptoms. 33% are going to experience incontinence postpartum. So that's a fact. You're going to have 33% of postpartum women experiencing incontinence. That's a huge number. That's a lot of people. Now, remember, we have a lot of babies. So if you didn't get it the first time, you might get it the second time, you might get it the third time. Just the probability escalates just with the amount of children that we tend to have.
And does it get worse with each baby? Is it like the body's used up more and more with each baby, so now everything's looser and looser with each birth?
Every birth will affect you differently.
So first, you're not going to see an improvement unless you do something from one birth to the next.
No, okay, unless you do something, it will not get better.
Okay.
Yes, the incontinence situation is moving in one direction. Yes, it will definitely only get worse. It will not get better. And then there's a whole host of other things that postpartum women are experiencing. Prolapse is extremely, extremely common.
Which is?
Prolapse is when the organs in your pelvis, right? So you have the uterus, the bladder, the rectum, parts of your intestine, when they start to come down a little bit. So you have a whole bunch of supporting structures in your pelvis, right? You have ligaments, you have fascia. All those things can get loose, whether from hormones. For example, while breastfeeding, you have less estrogen in your body. That's going to cause just a general looseness and sometimes even a brittleness in the tissues throughout your body. Also, when you're giving birth, you're naturally, everything's getting stretched out, and especially the way that most women are told to push during guided pushing in the hospital. They say, hold your breath, make like you're pooping, go to the bathroom, like that. That puts a tremendous, tremendous amount of strain on all the structures in your body and could cause the organs to kind of come down a little bit. Now, prolapse can refer to the organs coming down just a little bit. So, it's not really terribly noticeable. Most women who have prolapse are asymptomatic. They won't have any symptoms, or they'll have like a small symptom, like, I feel like a little bit of a heaviness, like at the end of the day. But then you have some women who have more symptoms. They have, even if you're not seeing anything from the outside, still, you might be having lower back pain. That's actually a prolapse symptom. And then, of course, there's more serious forms of prolapse where the organs come down a little bit more. Sometimes they're completely out of the body.
In which case you need surgical intervention.
Not necessarily. That's the thing. Not necessarily do you need surgical intervention. And sometimes the surgeries can have permanent side effects that women are not happy about. And a lot of women actually elect not to do surgery. And instead, they elect for non-surgical options like pelvic floor therapy. And there's multiple different kinds of pessaries for various different kinds of issues, depending which organ it is that's kind of falling out or, just falling into the vagina, depending on the degree. Pessaries are actually a fantastic option.
Is this something a woman feels on her own?
Prolapse?
That she has prolapse?
It depends on the degree.
Or is it something that she just doesn't feel well and she has no idea what's happening and who to go to?
That depends on the degree. So sometimes you might be experiencing symptoms like, I feel this heaviness. I feel like when I pee, not everything's coming out. I feel like when I defecate, not everything's coming out. But, nothing's standing out to you. And then you go to your gynecologist and your gynecologist says, you have prolapse. Sometimes it's a little bit more obvious than that. So that gets into some of the more interesting things that I've seen. So I have seen a woman who had, it's sometimes, there's different terminologies, but sometimes known as precedential, when like the entire uterus is just coming out. It has exited the vaginal cavity. So I remember that woman actually, so this leads into, things that are specific from women. That woman had delayed getting care, delayed it until she absolutely couldn't anymore. So let's back up a little bit. Prolapse can cause trouble with bedikas because one of the symptoms sometimes is a discharge, especially when the uterus itself is coming down. So she had been experiencing that. She had been experiencing a lot of trouble with her bedikas. So she had delayed getting care because she was worried
And when you say trouble, she means she couldn't physically do it, or
She could physically do
her
it.
Dika was coming out not
It was
kosher.
coming out with blood.
Right, okay.
So she didn't want to get help because she was nervous that it was going to cause her to become a nida, and then she was going to have to start all over again.
I don't understand the logic. Getting help would cause her to be more nida?
Yes.
Because she thought it would be surgical.
Not necessarily surgical. She was worried that getting, a pelvic floor therapy appointment, just getting any kind of exam was going to cause blood.
Okay. And can we make a public service announcement that most internal checkups that may cause bleeding are not nida bleeding? So people shouldn't be nervous to go get checked?
Absolutely.
Annual pap smear, or it's not annual anymore, or whatever it is.
Triennial, yes.
That's a myth. Say it in your words.
Absolutely. So first of all, most of these things do not make you nida. Whatever goes on during pelvic floor therapy does not make you nida. If you ever have a question for your Rav and you want your pelvic floor therapist to speak to your Rav about what they did, I can tell you, at least from my end, I have absolutely no problem speaking to a Rav and explaining exactly what went on. I did it for that woman, explaining exactly what goes on in an appointment, and I would happily do it again. What we do does not make you nida. We're not going into the uterus. If any blood is seen, we can assume that it came from other things. You can always go to Bodekas if you're not sure, or, we can look and we can tell you, which actually I had a story with that too. There was somebody who told me that she had some bleeding, and so she and her husband separated and she's nida. And I took a look at her and I said, that bleeding is not coming from inside. She said, yeah, it was just like a little spotting, but she saw it on toilet paper and she's Chabad. So that made her nida. And again, like all these stories, I'm changing details here and there so that you're not hearing real patient stories. But I took a look and I said, that's absolutely not coming from your uterus. That is coming from somewhere else. And I could see where it was coming from. So again, pelvic floor therapy will not make you nida. If you're having an issue, absolutely bring it up. But also, if taking care of your health were to make you nida, and if it was going to cause a concern, that is not what Hashem wants from you. Take care of your health first. You can worry about that afterwards. And again, there's not that much to worry about, really.
Okay. How about pelvic floor related that has made somebody nida? Because you'll have the person who's like, but what if I'm that one?
I honestly can't think of anything that we would do unless you hold by one of the more strict opinions. Right, then it would be that. But like according to the way that a lot of people, especially people in my community, practice Taharas Mishpacha, it would be very, very, very difficult to become nida from pelvic floor therapy. I'm aware that other people don't hold this way, but my Rav holds that if you know that the cervix was what was touched and then there's blood, you can assume that it was from the cervix. And again, we're not really engaging with your cervix during pelvic floor therapy. It's just that your cervix changes position throughout your cycle, or various things that happen in a woman's life, or again, prolapse. If we know we touched your cervix, then, you might be able to talk it up to that. There's a million ways to not become nida from pelvic floor therapy, and I can't think of one way to become nida from pelvic floor therapy.
So you mentioned prolapse. What else?
Oh, there's a whole list. So I was going through the Jewish woman's life cycle. So we've got pregnancy. So pregnancy can cause incontinence, prolapse. One of the things that people don't talk about actually is constipation, which is somewhat related to a very familiar issue that many people talk about, which is diastasis recti. Now, if you're hearing me say diastasis recti, it's the separation of your abdominal muscles. So you have your rectus abdominis muscles. They kind of go down in a straight line. Those are your abs. That's where your six pack is. They go down in the front of your abdomen. When you're pregnant,
the imaginable.
Yeah. Once you hit a certain point of pregnancy, you are going to have diastasis. They are going to split. That's normal. That's natural. Hashem made it that way. There's actually some studies showing a decreased incontinence in women with a greater diastasis as opposed to women who have a lesser separation. So that's how Hashem created us. It's normal. It's natural. But once you give birth, most women say, hold on, I have a pooch. Like I have like a little bit of a belly. And that's when you really start to notice like, oh, I still look pregnant. And that's when most women notice their diastasis and they want it gone. So then you have women, exercising, they're trying to fix it. So that's a much more common issue. But what people don't realize is because your abdominal muscles are weakened and they're separated and they're not in place and working like they should, your intra-abdominal pressure, the pressure inside of your body, actually goes down. So you kind of have like a double whammy there. When you cough, it goes up and your pelvic floor is weak because you gave birth. So you're leaking. But also the pressure in general is kind of low. So the food in your intestine is not moving through the way that it should. And so you end up with constipation. So yes, pelvic floor therapy can help with constipation. I feel like that's kind of one of our, that's our latest frontier. People are aware if you're having trouble right after you get married, consummating your marriage, you go to a pelvic floor therapist. That everyone's aware of. People are aware if you're leaking urine, you go to a pelvic floor therapist. And if you're not aware, your doctor's probably aware. Constipation is kind of like our next frontier. I can say it so many times. I've told people, I can help you with your constipation. They're like, really? And then they're like, wait, what do you do for that? So the answer is a number of things can be done for constipation. There's the kind of lower intervention things, fix your diastasis, strengthen your abdominal muscles, learn to push properly in the toilet. Don't strain. This is if we take anything out of this podcast, if our listeners take anything out of this podcast, it is do not strain on the toilet. Do not strain. Invest in a squatty potty. It's like $20 on Amazon, even cheaper.
What did you say? Do not strain.
Do not strain on the toilet. So you know how they, like I said,
pushing.
Yeah, don't push on the toilet.
Okay.
That is my public service announcement to you all. The way that they tell you to push when you're giving birth, you're holding your breath, and you're going, right, like that. Don't do it. It's bad for your pelvic floor. Just don't do it. It can lead to prolapse. It can lead to all sorts of unfun things. Instead, try getting yourself a squatty potty. It's really cheap. It's just a stool. I have so many people who tell me, yeah, I just use the basin that I use for Nagelwasser. I turn it over and I put my feet on it. And no one told them to do that. It's just instinctive. I love recommending the squatty potty just because it's curved and it fits around your toilet seat. So it's just like easier to store, but and it's wider. So you can keep your legs wide, which also is more conducive to having a good poop. But really anything will do.
Toilets are not designed for the way the body's designed to poop. And if you want to know how the body's designed to poop, just look at a little kid in a diaper.
Absolutely.
Squat.
That little 2-year-old in the corner pretending like no one could see them. Yes, that is how humans are supposed to poop. If you look at, people who are like squatting to poop in other countries where it's more common to,
a hole in the floor.
Yeah, use a hole in the ground. Think about it. They're squatting. Exactly. They have their knees above their hips. That's how you want to be doing it. You want to have your knees above your hips, right? There's always like little tips that, people are just finding out now, they're like, in their 30s. I've educated women who are like in their 50s. I'm like, why didn't we cover this? Why didn't we cover this earlier? That's another pet peeve of mine that we can get to later, about the education or lack thereof regarding women's health. Some of my friends, the extent of the education they received was, you're going to bleed once a month and you're not dying. That's not enough. That is definitely not enough.
But also the doctors don't even have some of the education that you have.
Oh, yes, absolutely. Absolutely. And it's really, really not that hard. It's really not that hard to educate yourself, to keep yourself aware of what's going on. Problem is that sometimes medicine divides people up into parts, to the point that I didn't even know this specialty existed until a few years ago. But you have gynecologists who also a lot of times are obstetricians, but then you also have urogynecologists who deal with the urology aspect of a woman's body. People don't even know that urogynecologists exist. And, there's a reason that they exist, but at the same time, we have this separation, this kind of blind spot, which people have been speaking about this for years. This is nothing new, where, you have medicine dividing people's bodies up into this issue, that issue, that issue. And sometimes you're missing the bigger picture. You're missing the systemic issue. So, I'm an occupational therapist. So that's a lot of my training, to look at the bigger picture of your life, of any red flags that might indicate that you need to go back to your doctor and ask better questions, or educate yourself. And sometimes people need to educate their doctors. I've had stories where doctors also just weren't aware of things that are available, measures that are available to help their patients, or they're just not trained in them. Finding somebody a pessary fitting is surprisingly was not as easy as I thought it would be.
Which is what?
So as discussed, the pessary is a small piece of plastic or silicone that goes up in the vagina, holds your organs in place. So that could be tough to find. As I was discussing on the chat, my other thing that I noticed that doctors are really not up to date with, many are, and I was educated about this by some fantastic doctors. I'm not here to be bashing doctors. They're amazing. Please go to them. Please get your checkups. But vaginal estrogen, that is one of the most, one of the things that has, I think, the most misconceptions around it. I had a patient who told me that her doctor said that she needed a mammogram before he could give her vaginal estrogen. False. Vaginal estrogen does not cause breast cancer. I had people who were told, oh, you need to take a progesterone along with your vaginal estrogen. Again, I'm not your doctor. Speak to your doctor. But that's not what the current guidelines are. That's not how how it needs to be used. And why is this so important? Because again, let's go back to that statistic. 84% of women eventually experience genitourinary syndrome of menopause, which causes so many issues. It causes incontinence, it causes pain. I'm like speeding ahead to menopause here. We were at pregnancy before, but there's so many.
Yeah, finish the thought.
Yeah.
Anything else in menopause?
In menopause, yeah. Oh, menopause comes with like a whole host of issues, but a lot of the issues that we're seeing, sometimes I say that pelvic floor therapy is the new drink a glass of wine. Women used to go to their doctor and say, oh, I'm having pain with intercourse, or, I'm just having pain when walking. That's like some of the more severe cases. People would go to their doctor and say, oh no, I'm in pain. And the doctor would say, drink a glass of wine and try to relax. Now, to our ears, we're like, we hear that and we're like, that's inexcusable. That's terrible. That's awful. Imagine.
I had that.
What? You had that?
I had that. It's like your third kid and you're, whatever old you are, normal.
Oh my gosh. Oh my gosh. So many things. Yes, they're normal. If you look at the statistics, they're normal. Many people experience it, but that doesn't mean that's okay. It doesn't mean you have to live like that.
There's no solution. I got no solution. I was like, that
is
welcome.
Extremely common. They won't tell you to drink a glass of wine anymore, but it's, in so many words, they're basically telling you the same thing.
Well, I was pregnant, so maybe.
What happened? You don't have to share on the podcast, but.
No, I just felt like the baby was just sitting on my, whatever the exit is. I don't know which part of it was. And it was just so heavy and it was splitting it. Felt like, I called it creasyams. Just felt like being pregnant the last trimester was just creasyam stuff. I was walking around with something just stretching me out.
Wow.
Because there's weight on there. And the doctor's like, how old are you? What number kid is that? Well, welcome to the show.
No. So I happen not to be trained in this yet, but there's something called spinning babies. Like, this is their thing. They have all these various exercises that are designed to help you relieve the pressure. I mean, some of them are like really easy. I've taught them to people before. I mentioned them to pregnant patients and they're like, oh yeah, I saw it on Instagram. It's great. By the way, like, props to Instagram. Like, they're great. They're educating the population when the doctors are telling you to go drink a glass of wine. Actually, look this up. I think you'll find it interesting. There's something called an inversion, where you sit on a couch and you kind of turn over. You put your head on the floor and you're upside down. It looks whack. It looks ridiculous. But I did it when I was pregnant, when I was having pain, and it works wonders. It gets the pressure off your pelvis. It helps, and it can help for afterwards.
My whole 9th month.
That's fantastic. Sitting in the pool also helps. That takes the weight off of you. Helps with the gravity. Definitely. There's so much to do about that. There's so much to relieve the pressure, to think about what's the issue here. Like, where's baby sitting? Maybe we can strengthen this or stretch that to like give baby more room. That's more spinning babies techniques. And there's so many great pelvic floor therapists and actually chiropractors who are well trained in specifically this. And for doctors to just say like, oh, there's nothing to do about it. No, there's nothing for the doctor to do about it because it's not their wheelhouse. Doctors don't do occupational therapy. Doctors don't do physical therapy. Doctors don't do chiropractic, and that's fine. You're for out. No, but just know that it's available, that it exists. I don't want to put the blame on people. There's been just an explosion of awareness in the past few years that just didn't exist before. But at the same time, get educated. Get to know what's out there and, what you can refer your patients to. Actually,
especially since it's your field. It is your wheelhouse.
Exactly.
You should know what's available out there. Okay. So next, after pregnancy, did we cover most of the things in pregnancy?
Yeah. So we said constipation. Oh, tears. Healing from tears. That's also another one. So a lot of women tear or they have an episiotomy when they give birth. And you definitely want to address that in pelvic floor therapy. Why? Because you want that skin where the tear is, you want it to heal well, and you also don't want the scar tissue to limit the mobility of your skin. That's a recipe for tearing again. And it's also a recipe for some other things. I've seen somebody who her tear healed, I think it might have actually been an episiotomy. Her tear healed kind of in a way that it was kind of pulling, and she ended up with a fissure. She started to tear from the rectum as well. She ended up with an anal fissure. Those are super painful. So thank God she had a very knowledgeable doctor who sent her to pelvic floor therapy. And she was able to get help. But what we can do about that is scar mobilization. So we want to massage the area, move the scar. We can teach you how to do that for yourself. Virtual pelvic floor therapy is fantastic if you can't access pelvic floor therapy in person, and it can hopefully help prevent tearing in the future, but also prevent issues that are occurring, in the here and now. Then, of course, once we're getting to scars, we have to talk about C-sections. just with the number of babies that we have in our community, C-sections they're common. They're out there. I mean, our C-section rate in the US is way too high, but it happens. It actually has some side benefits, lesser risk of prolapse. You're not out of the woods in terms of your pelvic floor because you had a baby sitting in there for 9 months. But in terms of prolapse, there's a lower risk of that with a C-section. But the healing, they cut through so many layers. I think it's 7 layers they cut through when they're doing a C-section, right? And all you see is this little incision on the outside, but they cut through so many layers. And afterwards, part of your recovery should be going to pelvic floor therapy. You need to get that scar mobilized. You need to make sure that it's not sticking in one place. You need to make sure that there's no adhesions forming inside of the body. I like to use the analogy that scar tissue is kind of like glue. So it kind of sticks things together inside of the body, right? We don't want that. We want to keep it moving. We don't want things to be sticking together, right? That's another case that I've seen where the uterus and the bladder were kind of stuck together from repeat C-sections. And as this woman progressed through her pregnancy, she started to experience like some pretty severe incontinence because the uterus was kind of like pressing down on her bladder and they weren't separated. They were kind of like stuck together like that. Could we have prevented that? I'm not sure, but pelvic floor therapy definitely can help with the scar tissue issues that come up. It can definitely help you fix that. And, you want to be able to have full mobility. You don't want that scar to kind of like be stuck there. And it can definitely help with that.
So C-sections, what's next?
So we said C-sections. Okay, so here's just another point that I wanted to make. I remember when I was training under a PT who was new to the Orthodox community. And we were working in Borough Park. And she's just meeting all these women who are like, yeah, I have 10 kids. I have 8 kids. I got 15 kids. And they're like cheerful, like super cheerful about it. Like, yeah, I'm planning to have more. And she was like, whoa. She's like, these people are running the birth marathon. I was like, that is such a great way to put it. This isn't just like a sprint where it's like, okay, let me just get through pregnancy and then it'll be fine. Let me just get through breastfeeding and then it'll be fine. Let me just, get through this postpartum period and then it will be fine. No. This is the marathon. If you plan on having...
This is the lifestyle.
Exactly.
It's like
this is
the pregnancy, the breastfeeding, and then back to pregnancy.
Exactly. Treat this like with the dedication that runners treat training for a marathon. You're going to have to work at this in order to stay healthy. So there's no waiting it out because you're going to do it again, right? And think about it. First of all, once postpartum, always postpartum. Once you've given birth, you're going to have issues, if you're going to have issues. But for most people, whatever it is that happened after birth, your body's forever changed. Your body's forever changed. If they dig you up in 1,000 years and they dig up your skeleton, they'll be able to tell from the way that your bones are positioned that you had a baby. Your skeleton is forever changed. Your tissues are forever changed. Your muscles are forever changed. And that's okay. That's great. It actually prepares your body for the next baby once you've given birth once. That's why they say the second one just slides right out. That's why, because, you've already kind of your oldest kind of paves the way. Yeah, that flashback. I've apologized to my mother. My head was in like the 90s of percentiles, and then I'm the oldest, and my next sister was a 25-minute labor, so that does happen. Back to I was saying just about the birth marathon, right? There's no waiting it out. Whatever it is that you're dealing with, you need to take care of it, and you need to focus on your recovery postpartum. There's no such thing as like, okay, whatever, eventually, I'm sure I'll start feeling stronger. Eventually, I'll stop looking like I'm pregnant. Eventually, I'll stop leaking. There's no eventually, especially if you're planning on having more kids. You have to take care of it, and you have to take care of it now. So you don't end up, older and like the cumulative effect is now coming to haunt you.
Okay, what's next? I have questions, but I'm waiting for you to first get through your life cycle in case you cover something.
Sure. I'm just trying to think through what did we get? Oh, we got dekas, we got newly married, we got pregnancy. I mean, I didn't really touch on all the issues that could come during pregnancy, but just to know that we're here to help. Let's see, we did postpartum. So menopause, like I said, like the main issue that we see is leaking, but also we see painful intercourse. And like, again, that's like an issue that like no one wants to broach, especially with their doctor. People don't want to broach it. And again, you get told, drink a glass of wine or, suck it up. That's just how it is. There's nothing we can do about it. That's how it is when you're old. False. These are all classic GSM symptoms. Please get yourself some help. If your doctor is refusing to help you, go find a new doctor. It can be hard to find one, but once you find a good one, they're the best. There are some really compassionate, amazing doctors out there. So just to explain what's going on and why there's so much pain and why they're sending you to pelvic floor therapy, usually comes along with, there's incontinence, there's pain. They say, oh, you should go to pelvic floor therapy. But there's a limit to how much we can help you because some issues are not caused by a muscle. Some issues are caused by the fact that you have less estrogen in your body, and that causes the tissues to be more likely to tear. So someone's having intercourse, they're getting micro tears. It could be really, really painful. Like the classic thing, like the classic description is, I feel like I'm having intercourse with glass. That's when we send it. That's when we send patients right back to their doctor. There are actually some treatments that some pelvic floor therapists are able to offer, using shockwave therapy or radio waves that can actually help to rejuvenate the tissue and fix the underlying structure of the tissue that changes when there's not enough estrogen. Those machines do exist, and sometimes we can help you, but more often than not, that's when we say you have to go back. That's why I say, like, it's the pelvic floor therapy is the new drink a glass of wine. Sometimes it's just, doctors who aren't aware of how they could better help their patients just saying, like, off you go. Usually it's not. Usually we are able to help you. And I've seen some truly, truly amazing improvements. But yeah, pain during intercourse is something that, like, people are so scared to bring up. Sometimes they assume that there's nothing they can do about it. And it couldn't be further from the truth. Throughout my education as an occupational therapist, even just like in regular OT school, they kept drumming it into our heads. And I think that some other medical professionals need to be aware of this as well. Older people are still sexual beings. Older people are still having intercourse. Older people are still entitled. They have a right to that part of their life. And you are never too old to get help with that. And if a doctor tells you, well, you're 89 or, well, you're 109, new doctor. Immediately, new doctor.
You're fired.
New, whatever medical professional it is. If it's occupational therapist, physical therapist, whatever it is, somebody tells you you're too old, new practitioner, because you have a right. You have a right to that, whatever stage of life you're in.
Questions for non-hospital classic style birthing positions. I hope this.
Oh, I forgot to touch on birth. That's a good question. Yeah.
Okay, let's do birth a little bit. Are there less side effects, like tearing and other
from
things?
other positions?
Meaning, are we designed to not, and I've heard it before many times, like the hospital position is not what it's supposed to be like. So we're ultimately hurting our bodies by doing it the doctor prescribed way.
So the origin of the classic birthing position, right, where you're laying on your back and you've got your legs off and everyone's yelling at you, push! It comes from one of the French kings. I believe it was Louis XVIII, but I'm not sure if I got the number right. There were a lot of Louis. But one of the Louis had a thing where he liked to watch his wives giving birth. And that was the easiest position for him to watch them in. So that became the position. It's also the easiest for the doctor to deliver the baby in. But it does come with a higher chance of tearing. Think about it. You have gravity acting on that baby's head, kind of pulling it down on your perineum. That's where the tears usually happen, of course. So that's one of the issues. The way they tell you to push also increases tearing. You're increasing your intra-abdominal pressure to such a degree when you're straining while you're holding your breath. You're increasing the pressure so much that sometimes the baby actually comes out quicker. That's why I advise women to wait when the baby's crowning. Give it a second. It's really hard. I've been there. It is really, really difficult. But wait for a second, because if you give that big push and the baby flies out, you're more likely to have a tear. Give it a second, let your tissue stretch. But yeah, definitely.
It's easier to do on an epidural.
So on an epidural, it may be easier to wait, but on an epidural, you're more likely to be giving birth on your back because it's harder to recruit the muscles that you need in order to give birth in any other position. So if you get an epidural, you are more likely to tear just in general. Those are the stats, and you might end up on your back. If your body is telling you to push on your back, push on your back. One way to make it better is to put a towel underneath. It's kind of hard to describe it over audio, but lower back, as low as you can get pretty much. It gives a bone called the sacrum more room to kind of get out of the way and bend out of the way. Another way is to take your knees and bring them in so that your knees are more toward the middle of your body than your feet. But your knees do not need to be together for this. You're kind of rotating your hip inwards and your leg is going outwards. And that will actually make you some more room in the pelvis to get your baby out. That's one of the other drawbacks of pushing on your back. You are decreasing the amount of space available for your baby to move through. And you're also acting against gravity because the baby's coming down, but then it has to go up a little bit. If you have to push on your back, not the end of the world. We take these little tips and you try to make the best of it. But if you're able to push in any other position, squatting on all fours, throne position, all of these wonderful positions that are available, whatever floats your boat, those are probably better options. There's also birth stools. That position actually sitting, there's a reason why they call the toilet the dilation station. It brings the baby down while you're sitting, just using gravity, the baby just naturally comes down. And if that's the most comfortable for you, go for it. Definitely always better to give birth not on your back. But if you have to, you know what I'm saying? Like there's so many people who like, they feel guilty. They're like, oh no, I gave birth on my back. I caused myself all these problems. No, if you gave birth on your back, you don't need to guilt yourself for the way you gave birth. It's just a good tip for people who can.
To do anything but the back, you have to be proactive, in America at least. If you're not proactive, that's what's happening,
Right.
because that's how you're led.
So if you want to make a proactive decision that will eventually lead to less tearing and more flexibility with things, you have to do that when you're seeking a provider. So personally, I actually chose midwifery care. I ended up giving birth on my back because I had an epidural and I couldn't recruit those muscles. But I actually used midwifery care, where they have a list of things that like, these are our beliefs about birth. And like, one of their beliefs is you do not have to give birth on your back. So you have to do your homework a little bit earlier. When you're choosing a provider, you want to choose a provider who has a low C-section. You want to choose a provider who isn't going to tell you, but if I delivered, this is things that people are really told. If I deliver you in that position, then my back's going to hurt. I can't be delivering people in positions like that all day because my back's going to hurt, which is like, I'm sorry, but the doctor's back hurting is not the concern when a woman's giving birth.
So did your work affect how you made birthing decisions for yourself?
Yes and no, because I did end up choosing to get the epidural. I was not able to give birth in another position despite trying, but I did choose midwifery care. I'm trying to think what other things that I did. I made sure to get a doula who would help me change my position throughout. You definitely need help with that if you have an epidural. When you're giving birth, you definitely want to be changing positions throughout. It helps the baby descend through the pelvis. So at the time, I hadn't actually trained in pelvic floor therapy formally yet, but I had, done my research. I was part of a group of students who brought in some guest lecturers in our occupational therapy school to talk about pelvic floor therapy. So with what knowledge that I had, I knew to ask for a pelvic floor therapy prescription, which again, my practice was fantastic about that. Like they just hand them out like candy, which anyone who works in women's health should be doing, because rates of postpartum incontinence, 33%, rates of issues during menopause, 84%, which actually gets me to another statistic that I wrote down here. The rate of chronic pelvic pain is 81%. That's most people.
Okay, so 3 more questions that I know of. Number 1, so when you say exercises and what we do in PT, and you could do it in person or virtual, can you just share what the exercises are?
Right.
Or what are they about, so people can emotionally, mentally prepare for what's happening?
Yes, absolutely. This is like the number one. Like everyone's like, but like, what do you really do in pelvic floor therapy? Like everyone's like, but like, what do you do? Like I said, like, as soon as I tell people what I do, they're like, all these things come out. They're like, I had somebody who said like, are they gonna like put a whole fist in me and then like turn the whole fist? I was like, no, like, where did you hear that? Turns out that is an old technique for perineal massage. Please don't do that. Please don't do that. That's a terrible idea.
It's a technique for what?
It's a technique for perineal massage, which is thought to decrease the chance of tearing, where you massage the perineum. I really should have spoken about that preparing for birth, but that is something that you can do. You can do perineal massage, kind of massage the area and hopefully prevent it from tearing. The evidence is mixed. But that was an old technique that they used to do, where they basically would like stick a whole fist in and then turn. That's an old technique.
And you don't recommend it?
No, 0 stars, do not recommend. You could use your thumbs. You can do perineal massage on yourself, but like, you can go to pelvic floor therapy for it also. Use your fingers. There's no need to use an entire fist. But people are like, so like, what happens in pelvic floor therapy? So let me tell you, first of all, number one thing that I want people to know is, you never, ever, ever have to do anything that you don't want to do. And I will not kick you out of my office ever, and nor should anybody, because you decided that you don't want to get an internal exam, or, you don't want to do this or that or the other thing today. That is your prerogative. I am here to work with you. I'm here to help you, and I'm here to meet you where you're at. So if you're not game for anything in the session, that is your choice. And hold strong, even if you're feeling pressured in any situation. It's your body. It's up to you. So what we usually do is we'll do an internal examination. We'll take a look at your muscles, right? You have a whole bunch of muscles inside your pelvis. Those are the muscles that are responsible for holding up your organs, for peeing, for pooping, for birth. Those are the pelvic floor muscles. So just like, your shoulder muscles, right? You're having an issue with your shoulder. You go to physical occupational therapy, someone's going to take a look at the muscles of your shoulder, test them to see how strong they are, see if they're too tight. So that's what we're going to do. In a pelvic floor therapy appointment, with your permission and only with your permission, I'm going to use my fingers to check on your muscles inside and see how they're doing. If they're too tight, which is often the case when we have somebody who's having pain with intercourse, then we'll work on helping them to loosen those muscles. Side note, by the way, sometimes you have people with tight muscles who are still having incontinence, because tight doesn't mean strong. So we're going to work on lengthening those muscles and getting them to be a little bit more stretched out and cooperative with you. That's what happens later on. That's what happens when we do internal work. So after I've checked on what's going on inside of there, I might work on your muscles. So same way you might get a massage, manual therapy on your shoulder, on your, any muscle that it is that you're having an issue with, we can do manual therapy internally. So we'll work with those muscles, try to get them to relax. Sometimes we'll use our fingers to help cue you when we get to the strengthening phase. Will help cue you to activate those muscles, which by the way gets us to Kegels. Everyone says, do Kegels, don't do Kegels. You should do Kegels, you should do them correctly, and you should do them with guidance because they're not right for everybody. So that's part of what we do. A huge part of what we do is we will give you feedback on how your Kegels are and make sure that you're doing them correctly. Some people use machines for this. If you've been to the urologist, you might have seen that. It's called a biofeedback machine. Personally, I think that a great way to do biofeedback is through the expression on the therapist's face. I'm going to put my fingers where I need you to move. And if you did it, you're going to see me going, yay, good, great, do that again. I think that works well. That there's, a whole host of machines that give stimulation to the muscles that we can also use. But that's the internal work portion. But a huge, huge portion of pelvic floor therapy, actually, you will do fully dressed. With a caveat, by the way, because we were talking about things that are specific to from women, please wear leggings to your pelvic floor therapy appointment or biking shorts or something like that. I cannot count the amount of women who have walked in wearing tights. It's not comfortable. So a large chunk of what we're doing is actually going to be fully dressed because you can activate your pelvic floor muscles or stretch them.
When you're doing a podcast or brushing your teeth.
Exactly.
Right? That's not what you're going to say.
Well, yes. I mean, there's every time you see a red light, do 50 Kegels, that classic advice, which might be right for some people. But I was actually heading in a different direction. A lot of other exercises, things that you might not expect. For example, people might be familiar with the exercise of bridging. It's a fantastic exercise. Use it all the time. Bridging with something while squeezing something in between your knees. That's kind of you're laying down. You have your feet like this.
Down,
right?
Knees
feet
up.
Down, knees up, head down. And then you kind of lift your body up and you're holding something in between your knees. You can activate your muscles. There's a study that shows that you can activate your muscles, your pelvic floor muscles more that way than through doing a Kegel and through actually trying to actively squeeze your pelvic floor muscles. You're getting a ton of activation that way. Bridge with the block. Exactly. Bridge with the block. There's so many stretches that we can do to help your muscles relax that you can do fully clothed. So I personally don't treat men, but I have observed treatment of men. And that is also a huge part of it is stretching, which by the way, that's a great segue or side note, men need pelvic floor therapy too. I personally don't treat men, but I know who does. And most men are way too ashamed to go through there. I think that the male patients that I've seen are some of the most brave people out there. Men absolutely need pelvic floor therapy.
So what are some issues that would cue a man to go to pelvic floor?
Incontinence, erectile dysfunction, painful erections, difficulty initiating a stream, constipation. Constipation is probably one of the most common ones. Fecal leakage, urinary leakage. Some of the same things that concern women, but some things that are very different. And again, and prostate cancer. A lot of prostate cancer patients become incontinent, and that is something that a pelvic floor therapist can help with. Again, not me, but somebody else. Being a man, it's very hard to kind of humble yourself to go to a pelvic floor therapist. It's like going to any other doctor, any other medical provider. Take care of yourself. Do it for yourself. There's men who are suffering because absolutely not. No way, no how. I am not doing that. I'm not subjecting myself to that. That's why I say the ones who actually show up and come to the office, not only are they brave, but they also get their problems fixed. But yeah, huge advocate for pelvic floor therapy for men.
And how long does it take for problems to get fixed?
In general? Yeah. So really it depends on the issue, but also depends on, are you doing the work, right? We're going to give you a ton of exercises to do at home. And by a ton, I mean not that many. We're going to give you exercises to do at home. You have to do those exercises. If you don't, you still might feel better because the internal work does accomplish a very nice amount. Sometimes we'll use tools to help it along the way. And again, you have to follow up with your home program. So we'll use dilators. Well, now they're known as vaginal trainers. We'll use vaginal trainers to help you to relax your muscles. Sometimes we'll use weights to help you strengthen your muscles. Sometimes, I personally don't do this, but some pelvic floor therapists will have you order a machine that uses electrical stimulation to strengthen the muscles, and then they want to have you use that at home. There's so many different things that we might advise you to do. We might advise you to change your diet. We might advise you to incorporate more fiber if it's a constipation issue, or to stop drinking bladder irritants like coffee. Sorry, everyone, I'm coming for your coffee. We might advise you to change your diet in some
You're
way.
taking away the wine and the coffee.
The wine, the coffee, and the carbonated drinks. Yes, your seltzer has to go too. Not necessarily, by the way. If you're not having issues, please continue drinking your stuff. But like, if you're having any leakage, bladder issues, coffee, alcohol, and carbonated drinks are all bladder irritants, and they all gotta go. Sorry.
Fantastic.
So yeah, if you don't keep up with all the things that I would tell you to do at home, your recovery might take longer. We can still help you. Like we're still working on you in the appointment in the event that you consented to internal therapy, but your recovery definitely depends on how much you're working on things at home. I've seen some from session to session, like someone says like, oh, I'm like already 50% better because they worked on themselves and they worked hard on themselves. Some people have issues that are a little bit more difficult to heal, and those might take 2 months, 3 months.
It's still quick turnaround.
Relatively, yes.
That a doctor will tell you that's your life.
Exactly. No, it is never your life. It is never your life. Chase your cure, chase your healing. There's no reason to suffer. There's no reason to suffer. Just in general.
Are you going into Kala classes because it's a natural segue? Are you passionate about helping from women specifically?
Both. So like I said, I kind of have a bone to pick with how we educate. So the number one thing that I have a problem with when it comes to Kala classes, and I'm going into this because I want to do it better. The number one bone I have to pick is even the most educated, the nicest Kala teachers who mean well. They're saying they scare the living daylights out of Kalas. Your first time, it's gonna kill. It's gonna hurt. It's going to be so bad. You're gonna wish you were never born. Like, okay, I'm being a little dramatic, but so are they. Yes, it might be a little uncomfortable, but it should never escalate past the point of discomfort. And if it is, please seek some help. Please seek some help, please. But telling Kalas that it's going to hurt only sets them up for very unpleasant, traumatic sometimes experiences, ignoring an issue that really is a problem, whether it's a physiological issue, such as, they might need to get a procedure done at the doctor. Sometimes you have a hymen that's imperforate, or it has a septum that's, the vagina is like a little bit too covered over by the hymen, and you need to go get help for that. Sometimes it's an issue called vaginismus. That's when you can't penetrate at all. The more common one is dyspareunia. It's 21% of women experience dyspareunia. That's pain during intercourse. If you're having that, that's a problem. And that is a massive disservice that some Kala teachers are doing, where they're saying it's going to kill, it's going to hurt, just get yourself through it, just do it and get it over with. No. Please don't. Please do not do that to yourself. You deserve better. Take it from me. And I'm here to deliver better, honestly. I just want to be there for women and give them the options that people just don't know exist.
Would you recommend having a Kala go and check out her situation just to see if her hymen's covered more than normal, just to guarantee painless first time?
You should just in general, you should have a gynecological exam before you get married. It's probably a good practice. It's not the end of the world if you don't. But anyway, if you're coming to pelvic floor therapy,
a gynecologist will tell you this kind of stuff?
Oh yeah, sure. They'll notice that. If you're going to come to pelvic floor therapy anyway, I don't want to be the first one to be examining you. So you would have had to have gone to a gynecologist anyway before you land up at my doorstep. But definitely highly recommend Kalas should just go get checked out. And again, you do not have to consent to anything you don't want. So I remember I was very nervous about getting a checkup before I got married because I didn't want to get a pap smear. I did my research and, I was young, and it turns out anyway, they updated the guidelines. They wouldn't have given me one anyway, but I didn't want a pap smear and I was all scared about getting a pap smear. Don't be afraid. Don't be afraid. The other thing, by the way, that I want to touch on is that you have some Kalas who they're doing like a 5-minute phone consultation to get their birth control. Please don't do that. Please go to a doctor, see them in person, and get your birth control prescribed that way. Which, by the way, is another topic that I just wanted to hit on. Your birth control might be causing pelvic pain. Various forms of birth control can cause all kinds of issues. We touched on genitourinary syndrome of menopause, also known as genitourinary symptom of hormone deficiency. Could be caused by birth control, by the combined pill, by any hormonal birth control. Other forms of pelvic pain can be caused by copper IUD. I know somebody who ended up in the hospital because she was in such pain from a copper IUD. She thought she was having an ectopic pregnancy. Thank God it wasn't that, but these things are pretty serious. And by the way, that's another thing that affects our community. Everyone goes on birth control before they get married. This is like everyone but everyone. And then they end up staying on it. And, people are on birth control at various forms in their lives. And you should know the risks. You should know the risks. Like I said, 5-minute consultation, not enough. Please, sit with your doctor and, talk it out. You had Dr. Hellman on last week. She's a great resource. There's so many issues that get caused, and especially by the specific forms of birth control that women are using, because we don't use barrier methods. So, sorry, I should say many women don't use barrier methods because they say that they're either for some barrier methods, they incorrectly assume that they're usher, or they are actually usher according to your rabbi. So people are using these more heavy duty options that are affecting the body a lot more. And then they're wondering, why am I having pain? Why am I having this issue? So just wanted to touch on that it's, also a very common thing that happens.
Why does everyone automatically go on birth control before they get married? It's to regulate their period so they're not needed
to avoid chlupas nida. Chlupas nida, not the end of the world, but it makes sense for a lot of women to go on birth control to avoid having their period on their wedding day. Perfectly normal thing to do and perfectly understandable. And I'm not saying that women shouldn't use birth control. The problem is that women are not being adequately counseled. I'm saying this because I've seen it. 5-minute consultation is just not going to do it. And then another thing that people aren't being counseled on the risks is SSRIs, which I also wanted to bring that up because that's like just super common. Like such a large percentage of the population is on SSRIs.
What's SSRI?
Sorry, SSRIs are a class of psychiatric medication. So Zoloft, Prozac, I believe Lexapro, the like.
Antidepressants, anti-anxiety medication.
Yeah, they can cause, but not all of them. Not all antidepressants, not all anti-anxiety medication. I'm talking specifically about SSRIs. They can cause vaginal dryness, which can cause pain during intercourse. That's very easy to fix. You just use a lubricant. But the more serious issue is that they can also interfere with sexual responsiveness, sometimes permanently, even after people have stopped using SSRIs. Just something that people need to be counseled about before they go on these medications, which is just more of a side note. As a pelvic floor therapist, that's not the thing that I'm doing. But sometimes it does complicate things. Somebody's on an SSRI and then they come to pelvic floor therapy, they're saying, I'm having pain. That's the reason. And there's not much I could do for that particular thing. Back to the education aspect of things that I just wanted to discuss a little further. There's just a lack of knowledge about anatomy. You have people that are getting married, they don't know their own anatomy. You have men who struggle with understanding female anatomy. We definitely need to, as a society, kind of shape up with that, educate people better about their anatomy, educate people better about what are you expecting as a woman throughout your life cycle. People don't, while you're pregnant, people don't tell you where you're going to expect postpartum. And the side effects are, not the side effects, but the after effects, they're so common. So many people are experiencing pain, incontinence, prolapse, all these things. Pain after giving birth, super common. And people don't warn you because they don't want to scare you. But forewarned is forearmed, and we're not walking people through. We should be walking girls through what are you going to expect throughout your life and where can you get help for it?
Over the course of their life, not like dumping all that information 5 seconds before.
No, you don't have to like dump the information on people's heads, but some high schools offer a health class. That's a great way to, mention things, plant the little seeds. Doesn't feel as overwhelming when it doesn't apply to you. It's stuff that applies to other people. So it's not as scary when you're hearing about, when you give birth, you should have a lactation consultant, a pelvic floor therapist, a GI doctor, all lined up before you give birth, so you're not searching for them afterwards. That doesn't sound overwhelming to somebody who's a kala. And, kala maybe because they're busy with stuff. Doesn't sound overwhelming to a teenager who's like 18 years old and like this is not their life now. Doesn't sound overwhelming to them. It's just like, okay, good to know. Like, cool. Like pelvic floor therapy could help you if you're leaking after birth. Okay, cool. They're not leaking now. It doesn't bother them.
Do you know anything about IUDs and pelvic floor? Do you have anything to say about that? Okay, great.
Yep. Yeah. So depending which IUD you're using, but first of all, the pain during insertion can be bad. I am a very big fan of getting it done under anesthesia, general anesthesia. I've met a bunch of doctors who are also very big fans of having that done under general anesthesia. Unfortunately, it's very hard to find, but there's this disparity that you'll see throughout medicine where for a testicular ultrasound, men will be offered to be put under. And for an IUD insertion, women will get ibuprofen, which is ridiculous. But once it's in, your uterus is going to kind of cramp down on it. You're going to be feeling cramps. So they're going to be similar to period cramps, which also pelvic floor therapy can help with. There's been studies on this. We are here. We can help you. 81% of women suffer from pain around their periods. Dysmenorrhea is the term. And you don't have to suffer with it. We can absolutely help you with that. Which, by the way, point for the educators. When I was a kid, we actually had somebody come down to school and explain what periods were, and she went through exercises that can help you relieve your period cramps, which can also be helpful after IUD insertion if you're feeling well enough to do them. They can also be helpful after IUD removal. While the IUD is in, if you're having pain, definitely consult the doctor, because the risks of the IUD having migrated or perforated the uterus or ectopic pregnancy, those are all things that you need to talk to a doctor about. But an IUD could cause pelvic inflammatory disease, which is rare, but not very fun at all. It's inflammation throughout the pelvis, not very fun. We can help you with it, but it's a risk. It's a risk. You should know about that beforehand.
Right. Well, having a baby when you're not ready is also a risk. So everyone's away. But you can
100%,
find out which
100%.
birth control may be less risk for you.
100%. That's why you need good counseling. You need good counseling on which birth control works for you. And also, this is just the bone that a lot of people have to pick with the way that the reasoning is done. They say, what's going on is when you evaluate whether a birth control is safe and should be recommended to women, you're saying they're looking at it versus pregnancy. Is it better to be on this medication than pregnant? So the answer is always not always, but it's often going to be yes, because pregnancy comes with a whole host of risks and side effects that are much more severe than the various forms of birth control. But that's why men's birth control never made it to the market, the birth control pills, because being on the birth control pills was worse than not being on the birth control pills. There was no pregnancy to consider. It wasn't the same consideration as you would as women. So that's definitely something to think about when it comes to deciding on your birth control, whatever. It's more of a Dr. Hellman's kind of topic. Yeah.
Fantastic. Thank you so much for all this information, for taking out the time. Thank you, Faigie.
All right. Nice to meet you.
Thank you for watching until the end. This is the Franciska Show podcast. I am Franciska. This podcast is available on all your favorite podcast streaming apps. Please tell a friend, leave a comment here. Make sure to subscribe to my channel. If you have any comments or feedback, please reach out. My information is in the show description of this video. Thank you for watching my YouTube channel. This is a Jewish Coffee House podcast. So check out the other podcasts on the network, including Orthodox Conundrum, Intimate Judaism, and Chochmat Nashim. Thank you for watching, and see you next time.